Hello, this is Jessica Hoyt from Winona State University, and this is a presentation, a recorded presentation about asthma. So let me share my screen here with you really quickly. And let's see here. There we go. All right. So asthma, I just want to let you know that this is an abbreviated version of the information that's in your Lewis textbook from pages 549 to 560. So for further details, see your text. So what we are looking at when we're looking at asthma, thanks Jake, sorry, my dog's home today, is we're looking at a severe inflammation reaction in those airways. So basically, this is a pathophysiology review of asthma. And we need to remember that when we are prioritizing care, we often start with the ABCs, airway, breathing, and circulation. And asthma is an airway problem. So the inflammation that you see here in the middle is caused by predisposing factors such as genetic tendencies to develop allergies, female gender, especially in adults. So in peds, male gender tends to be more predisposed to this, but in everybody over the age of 18, female gender tends to have asthma problems more often than males. There are causal factors such as exposure to allergens, indoor or outdoor. There are occupational sensitizers, such as people who do auto body work with all those fine particulates that are in the air at their workplace, and anybody who is exposed to fine particulate matter in their job can develop asthma. There are also contributing factors like respiratory infections, air pollution. Tell you right now, with the wildfires that have been blowing around in the past, I'm recording this in August. So with the wildfires that have been coming out, the air pollution from those wildfires has really triggered a lot of people's asthma. Active or passive smoking, so that secondhand smoke can do that, as well as people who were born with a low birth rate, people who have certain diets, they're all predisposed to asthma in this severe inflammation of the airway. So what happens with asthma is we have these hyper-responsive airways which limit airflow. There are exacerbations such as allergens, respiratory infections, exercise, hyperventilation, weather changes, sulfur dioxide exposure. By the way, if you've ever cut an onion, you're exposed to sulfur dioxide. That's what makes all of our eyes tear. There are other things like food, additives in different things, and medication exposures that can also trigger airflow limitation from these hyper-responsive airways. And then we'll see symptoms such as wheezing, cough, dyspnea, that's that difficulty breathing, and chest tightness from this problem. So early manifestations, you can have a cough in your clients, or if you have asthma, I guess, with or without mucus. And the mucus, if it's present, may become lodged in that narrowed airway, right? So we can get a mucus plug up from that. Dyspnea, there's chest tightness, and then because the airways are so small, what happens is they can't get air out. So expiration, that expiring the air out, requires extra effort, and it's prolonged. So not only does a lot of times we think of, because the narrow airway, they're not getting oxygen in, it's really that the carbon dioxide can't be blown out and it's taking up all the space. And so because it's taking up all the space, then there's no real way for oxygen to, like, there's no exchange. So yes, oxygen doesn't come in, but not because of the narrowed airway in itself. The narrowed airway in itself prevents CO2 from being expelled through the airways, and it takes up all the room in the lungs. Because of this expiration problem, we will hear expiratory wheezes, those high-pitched whistling sounds. We'll hear them on expiration. We may also hear them on inspiration when we're auscultating, and we may not even need to auscultate to be able to hear the wheezing. When people have had an asthma attack for a really long time, these are late clinical manifestations. This is when if we haven't been taking interventions up until now, if they haven't sought medical care, if we're gonna get to care plans in just a little bit. But if these are the things that we see when an asthma attack has been going on for too long. So people get sweaty, they'll have diaphoresis, their heart rate will increase, they'll get tachycardia, they'll have widened pulse pressure. Widened pulse pressure is when their systolic and their diastolic increase. So instead of like the 120/80 that we're all kind of shooting for, or even less, like 110/75, they'll have 125/65, or even wider pulse pressures than that. Hypoxemia, where they don't have enough oxygen in the blood system, again, because the carbon dioxide can't get out, and so the oxygen can't come in. And then we'll end up seeing very, very late central cyanosis. Blue is a bad color in general, but blue is, we will see an asthmatic person, if they are blue, they are just about to have their complete respiratory failure. So we really need to get some interventions before blue happens. Hopefully they're able to come in to have us help them before blue happens. So for assessment and diagnostic findings, we'll see those assessment findings that I just talked about. We also want to take a history. So we want to see what they can share with us about, or maybe a family member that comes in can share with us about episodic symptoms of airflow obstruction, any positive family history of this, reactions to environmental changes like seasonal changes, high pollen counts, mold, pet dander, climate changes, air pollution, occupational exposure, any episodes of eczema, rashes, temporary edema. Eczema, rashes, temporary edema are inflammation reactions that we can see in the skin. So they can give us an idea about what has been happening with the person in terms of like outside the body, and what we can see in their integument, and then maybe get some ideas about what's going on in their airways. As well as we're going to be doing some lab work. So we're going to gather some sputum. That's people with asthma won't necessarily have a problem breathing due to infectious agents in their sputum, but we will see elevated eosinophils. In their blood, we'll also see elevated eosinophils. We'll see high serum IgE if allergies are the cause. And then we may or may not run ABGs, depending upon how many manifestations of stuff we're seeing. ABGs, we'll see hypoxemia, hypocapnia, and alkalosis. So as the fatigue increases and patient condition worsens, we'll end up seeing that CO2 increase in the blood too, because we're not getting it out of the body. So then it's going to go up in the blood because it's not able to go anywhere we want it to. And then just so that you're aware, if you have somebody who is presenting with severe clinical manifestations and they have the PA CO2 within normal limits, it's actually a sign of impending respiratory failure. And it's a big darn. So the other thing that we're going to be using is we're going to be using spirometry and peak expiratory flow rate, and perhaps a chest x-ray. A chest x-ray will help us rule out infection. And a peak expiratory flow rate, it's easy to confuse spirometry and PEFRs. I'm just going to go with that because expiratory just blows my whole speech thing out of the water. So spirometry measures the ability to bring air in. So when we're doing incentive spirometry or we're doing spirometry in general with a client, I tell them that it's like a vacuum. So I'm testing how much air they can get in. And a PEFR measures the air that the client can get out. So we can use these two measures either in combination or independently, but we want to make sure that they can get air in and air out. So we'll take some measurements that way. With this, I am going to stop sharing my screen, and because I like to chunk things into little chapters. So we're going to stop sharing now. I'm going to stop recording, and I will see you for chapter 2 of asthma.